CAR T-cell therapy has completely revolutionized treatment of patients with large B-cell lymphoma, with about 40% cure rate in heavily pretreated patients. But now that we have longer follow-up, we are starting to focus also on toxicity that may derive from the use of CAR T-cell therapy. In the pivotal ZUMA trial, looking into axi-cell, one of the two FDA-approved CAR T-cell therapies in our country, around 30% of patients after 1 month, so at time of first response assessment, had some cytopenia, defined as grade 3 or 4 reduction in neutrophils or hemoglobin or platelet count. But it's unclear whether this cytopenia may associate with shorter progression-free survival, higher risk of infections, higher risk of myelodysplastic syndrome, and we don't really know what's the dynamic of hematopoietic and, most important of all, immune recovery in these patients. So we decided to prospectively look into 31 patients who were enrolled in two different ZUMA trials of axi-cell, ZUMA-1 and ZUMA-9. And we selected specifically patients who were able to live up to day 30 when the first response assessment was done. And we observed that about 15 of these patients, about half of these patients, had grade 3 or 4 cytopenia at time of first response assessment on day 30. And we then tried to see whether having cytopenia at that time was associated with worse outcomes. We actually didn't see any difference in terms of response rate, CR rate, no difference in progression-free survival. There was actually a trend for a slightly longer progression-free survival in these patients. And most important of all, with pretty long median follow-up, more than 2 years, there was not a higher rate of myelodysplastic syndrome in these patients. We're still trying to validate further our data in regard to infectious complications, but we have very consistent data about immune recovery. In fact, this subset of patients has a very special feature, which is that we measure every 3 to 6 months on their peripheral blood by flow cytometry lymphocyte subsets. So we were able to see how these recover over time. And we saw that in the majority of patients, at 1 and 2 years, almost 100% of patients had a full recovery in CD8 and NK cells. But at 1 and 2 years, the recovery in CD4 count was not full. This is very meaningful for clinicians because many times we decide the type of antimicrobial prophylaxis based on CD4 count. And only 86% of patients at 2 years had a CD4 count above 200. So again, we need to validate more data regarding infectious complications, but potentially these patients may have a higher risk for infectious complications even 2 years after CAR T-cell infusion. And so these patients may deserve anti-infectious prophylaxis at that time, particularly toward opportunistic infection given the specific lack of recovery in CD4 count. As partially expected, only a minority of patients recover B cells. This is an on-target effect of CAR T. This typically targets CD19, so as a B cell marker. But again, we are trying to understand more about how this late recovery, particularly in CD4 count, may affect risk of infection in these patients, so that the community may come up altogether with universal guidelines on how to manage prophylaxis in these patients.